Good evening, everyone. Myself, Dr. Madhukiran, Academic Head, Yashoda Hospital, Somajigoda. I warmly welcome you all to today's session of Expert Appraisal on Emergency Medicine series, brought to you by Yashoda Hospitals in collaboration with SEMI. Today's topic is immense clinical relevance, acute decompensated heart failure in the ED, updated protocols and novel interventions. As emergency physicians, we encounter the heart failure patients frequently. Timely evidence-based intervention can significantly alter outcomes. This session aims to sharpen our approach using the latest insights and protocols. And it's my privilege to introduce our distinguished speaker, Dr. Neelu Sunil, Senior Consultant and Head of Department, Sparsh Hospital, Hennur, Bangalore. And she is the Vice President of SEMI Karnataka chapter. With vast clinical experience and academic contribution, Dr. Neelu is a strong voice in emergency medicine today. If any questions, you can drop in the chat box. At the end of this session, we will take over. Ma'am, can you take over?
Yes, please. Thank you. Thank you, Dr. Madhukiran. Thank you for the warm welcome and introduction. So today I would like to talk on the recent innovations in acute heart failure. I'll just share my screen. Are you able to see the PPT? 1 minute. Okay. So today's seeing the recent guidelines and the next generation therapies which have been proposed according to the AHA, the American College of Cardiology, and the European Society of Cardiology, and a few innovations in it, the management of heart failure. So according to the recent AHA guidelines, it emphasizes rapid, that was in 2022, which the guidelines were published. It emphasizes rapid initiation of quadruple therapy. We'll come to quadruple therapy. We'll be discussing it for heart failure with reduced ejection fraction. Then the European Society of Cardiology in 2021, they had published guidelines, which was again updated in 2023. They also have a similar approach with added focus on iron therapy and phenotype guided care. The common foundation is ARNI or ACE inhibitors, beta blockers, MRA, and SGLT2 inhibitors. So there are three main types of chronic heart failure. Heart failure with reduced ejection fraction, that is type 1, where the EF is less than 40%. Then you have heart failure with mild, very mildly reduced ejection fraction, that is called heart failure MREF, where the EF is between 40 to 49%. And then you have heart failure with preserved ejection fraction, where the EF is normal, but the left ventricles are unable to relax sufficiently to fill with blood. So there the heart failure ensues. So according to chronic heart failure guidelines, I discussed, the heart failure, how we have divided it. So you have in 2021, the guidelines didn't, specify on any disease modifying drugs. But in the recent evidence, they have updated the guidelines. The updated guidelines have disease modifying drugs for CKD, diabetes type 2 mellitus, which is included in the update. So what are the causes of acute decompensation in heart failure? So sudden drop in LV ejection fraction. It could be acute MI, Takotsubo cardiomyopathy, post-cardiac arrest myocardial stunning, peripartum cardiomyopathy, myocarditis, tachycardia-induced cardiomyopathy. The myocarditis could be viral due to SLE, giant cell, or any eosinophilia. So what happens when, and then you can have the other causes of volume alteration due to volume overload. When there's no discretion in your diet, you are not adhering to the diuretic usage, you have taken excessive IV fluids, you've been given excessive IV fluids without, they have not been doing the ultrasound guided bedside focus, and IV fluids have been given because the blood pressure is low. So excessive IV fluids can also cause a sudden deterioration in your heart. Then acute hypovolemia, that is over diuresis poor intake of fluids, or gastroenteritis. This can also cause heart failure. Renal failure can cause acute volume retention. So what are the arrhythmias which can cause this problem? You have bradyarrhythmias, tachyarrhythmias. Usually new onset AF can cause this. Decreased CRT pacing, increased isolated RV pacing can also cause this. Valvular dysfunction. So if you have any dysfunction in your LV outflow tract obstruction, so there it can cause. Prosthetic valve dysfunction can cause, because thrombosis in the prosthetic valves can cause this problem. Native valve dysfunction. If there are native valves and there's an endocarditis or there's a rupture of the papillary muscle, this can cause a heart failure. Some medications or substances which can lead to heart failure is due to non-adherence to heart failure therapy. Then there could be excessive beta blocker usage. So this can cause a decreased sympathetic drive, diltiazem, certain antiarrhythmic like class 1 and class 3 antiarrhythmics, drugs causing volume overload like NSAIDs, steroids, pioglitazone, all this can cause volume overload. So they have to be taken with extreme caution when anyone has already a pre-existing heart failure. Digoxin toxicity, cardiotoxic chemotherapy, sympathomimetic abuse. Other causes could be uncontrolled hypertension. So this can lead to hypertensive heart failure, uncontrolled sleep or disordered breathing, hypophosphatemia, iron deficiency with or without anemia, thyroid disease, that is hypothyroidism and hyperthyroidism, both can cause an acute heart failure. And infections, sepsis can also cause this. So what do you do in the ED? The initial evaluation is you do your core labs, you do your CBC, electrolytes, calcium, magnesium, phosphates, troponins are sent, LFTs are also sent. You do an ABG to see the bedside lactate, do a TSH, monitor the digoxin levels if they're already on digoxin. Iron studies have to be done, BNP and NT-proBNP. And imaging, so you do an ECG, do a bedside echo and a chest X-ray. So what does this show? So in a chest X-ray, you will see pulmonary congestion, you will see pleural effusion and cardiomegaly. In a CT, you can see a septal thickening. You can also see the batwing, characteristic batwing appearance which happens in pulmonary edema and pleural effusion. So someone who has a sympathetic overdrive, who develops a sympathetic overdrive due to, so this is called as a scape, which can happen in someone who's have a hypertension which is not controlled. So this is called a sympathetic crashing acute pulmonary edema, which is called a scape, where you have a ground glass appearance and there will be no septal thickening in the CT. When there's a pulmonary edema with no such overdrive, then you have a septal thickening in the CT. But when there is a sympathetic overdrive, then you will not see any septal thickening in the CT. Then asymmetric edema, where you can see asymmetric edema in MR, positional effects, pulmonary vein diseases. How do you manage this in the ED? First, you treat the lungs. So we are just going stepwise. First, treat the lungs. You treat the pulmonary edema, treat any pleural effusion, optimize the map. Do an afterload reduction and or you add a inopressor. Optimize the volume by inducing diuresis or giving very cautious fluids if the patient is hypotensive. Consider inotropes only with reduced ejection fraction. Treat the underlying cause. So whatever the causes you just said. So if any of those causes are present, please treat the underlying cause. Consider any mechanical support and avoid harmful interventions. So when you treat the lungs, what do you mean by treating the lungs? So you can reduce the preload and afterload by putting them on an NIV, BiPAP or a CPAP. You can intubate them early for who have a refractory. So if someone is not, you give a trial of an IV, they're not responding to an IV, please intubate them if they are in refractory distress or cardiogenic shock. Drain any effusion. So you have a effusion which is moderate to severe, please drain them because this can cause a severe respiratory distress. We need to optimize the MAP. If there is a high MAP or SVR, the systemic vascular resistance, we need to reduce the afterload. So this can be done by NTG infusions, giving nitroprusside infusions or giving nicardipine. A low map, if there's a low map then and they are hypoperfused, BP is low, then we have to give them inopressors like noradrenaline, or a low dose, very low dose epinephrine infusion can be started. Third, we optimize the volume. Fluids only if they're hypovolumic. So if they're hypovolumic and there's no pulmonary congestion, which is seen radiologically or by the bedside focus, then please give them fluids. Otherwise, you can start inotropes. Diuretics can be given, loop diuretics plus or minus thiazide diuretics. Diuretics are usually preferred IV because a tablet or in the oral form it is poorly absorbed. So the goal here to reduce the congestion and improve the renal perfusion. Inotropes, okay, are supposed to be used only for heart failure with reduced ejection fraction. So what is the indication where can we start inotropes is when they are hypoperfused, they have a low BP, and they have a refractory pulmonary edema which is not responding to whatever measures you've taken so far. Then you can start them on dobutamine, which has a short half-life and you can easily titrate it. Then also recently milrinone has to be shown to be very promising in such situations. It is a phosphodiesterase 3 inhibitor and it causes more pulmonary vasodilatation and that's why it is very helpful in RV failure. Digoxin is used in chronic cases, chronic AF, plus patient who has a reduced ejection fraction. So treat the underlying cause. If an arrhythmia is causing, then restore it to sinus or you manage the rate with whatever drugs or with synchronized cardioversion if it is unstable. If patient has an acute MI, then you need to do a PCI. And if PCI is not possible, please thrombolyze the patient. Severe anemia, we'll transfuse. Severe anemia is one thing which can cause a severe acute decompensated heart failure. So please manage the anemia. Transfuse blood if hemoglobin is less than 7 to 8 grams per deciliter. These are all according to recent guidelines. If they do require mechanical support despite whatever you have done so far and they are hypoperfused, the BP is really low and they're in refractory distress, we can put them on an intra-aortic balloon pump. This has been shown to show a modest cardiac output gain, but there's no mortality benefit. Then Impella is also beneficial in infarct related. So MI related shock, cardiogenic shock, Impella can be introduced. Then veno-arterial ECMO. This can be used in severe biventricular or combined cardiac plus respiratory shock. Okay. So avoid any harmful substances. So avoid any nephrotoxins if the patient is in cardiogenic shock. Avoid NSAIDs, avoid ACE inhibitors, avoid ARBs. Don't suppress compensatory sinus cardia. So sometimes when there's sinus cardia, we tend to give them beta blockers. This can even worsen the situation further. Avoid diltiazem or dilzem in compensated heart failure with reduced ejection fraction with AF. They should don't do aggressive fluid restriction. So sometimes this is very harmful. Don't do aggressive sodium or fluid restriction. And be cautious in beta blockers as we have discussed. So when you have a patient who has a chronic heart failure with reduced ejection fraction, how do we optimize such patients? We can start them on SGLT2 inhibitors or ACE inhibitors or ARBs or ARNI as they are called, or MRA. MRA, so we have, this is called as a quadruple therapy where we start them on SGLT2, ARNIs, MRA, and a beta blocker. Ivabradine, if the heart rate is greater than 70, despite your bundle, whatever beta blockers you have given, despite that, if the heart rate is very high, then please give them a ivabradine. You have to treat the iron deficiency, IV iron. So this is according to recent European updates that iron deficiency has to be treated because this can worsen the heart failure. We can give them IV iron infusions and consider varice guat in refractory cases. In heart failure with preserved ejection fraction, you can optimize them with SGLT2 inhibitors for most. Diuretics you can use for congestion. And you can control the rate. If the patient has a atrial fibrillation, control the rate with you can do a rate control of the AF. Target the blood pressure with to less than 130 by 80. Manage any sleep disorders like OSA and comorbidity. So any lifestyle modification which can worsen this situation, you can start them on some lifestyle modifications to reduce their weight, to uh, manage their diabetes better, to manage the CKD better. Avoid routine beta blockers unless indicated. So, what is the rationale for you using the quadruple therapy? So, ARNIs, they enhance natriuresis and they reverse the remodeling in the heart due to the heart failure. And beta blockers, they reduce arrhythmias, they reduce the myocardial oxygen demand. MRAs counters the aldosterone-induced fibrosis and the sodium retention. And SGLT2 inhibitors reduce heart failure hospitalization and cardiovascular deaths even in non-diabetics. So ARNIs, what is the mechanism of action? ARNIs also, the full form is angioreceptin receptor neprilysin inhibitor. So this is available as a combination of sacubitril bar valsartan. So what sacubitril does is it acts on neprilysin, inhibits it, and this decreases the natriuretic peptides, which increases the natriuresis and the diuresis, promote vasodilatation. Hence, this reduces the preload and the afterload. Then valsartan is an ARB. It is an angiotensin receptor blocker. It acts on angiotensin 2. It decreases the vasoconstriction, decreases aldosterone release. So hence promotes, decreases sodium and water retention. And this decreases the fibrosis and remodeling of the heart. This reduces the preload and the afterload. Why do we use SGLT2 inhibitors in heart failure? So SGLT2, these are sodium glucose transport inhibitors. They promote glucose and sodium reabsorption. They promote osmotic diuresis and natriuresis. This decreases the plasma volume and hence decreases the preload and the afterload. So there could be a mild BP reduction because of this, because it's decreasing the plasma volume, and but this also causes decreased ventricular wall stress. It increases the ketone bodies. What are the SGLT2 inhibitors that we know of? It is empagliflozin, dapagliflozin. They were usually earlier used as anti-diabetic drugs, but now they are being used for heart failure. And they also can increase ketone body production. This can sympathetically, it increases sympathetic drive and increases the ventricular muscle contractility. So decreases the oxidative stress and inflammation, and it is cardiorenal protective. So this is why we use. So ACE inhibitors, they reduce the preload and the afterload. Beta blockers decrease the heart rate and contractility. MRA decreases the fluid retention, and SGLT2 inhibitors decrease risk of hospitalization and cardiovascular deaths. So according to 2021 ESC heart failure guidelines, they only recommended heart failure prevention and diabetes, but the recent update includes recommendations for both CKD and type 2 diabetes mellitus. ACE inhibitors or ARBs are indicator for patients with CKD, diabetes and hypertension or albuminuria as per KDIGO guidelines, and recent trials also are supportive of this. So as we have discussed, there were a few trials which is done. It is on CKD patients and type 2 diabetes mellitus patients. One is DAPA CKD, one is EMPA kidney, and they all showed reduced heart failure, hospitalization, and CV deaths when we use SGLT2 inhibitors. Then there's another promising drug, which is finerenone, which can be used in diabetic kidney disease. And this has been shown to decrease the cardiovascular deaths and also reduces the hospitalization. So iron deficiency anemia was not a part of the guidelines earlier, but our Ironman trial, it showed a non-significant trend towards reduced heart failure, hospitalization, and CV deaths. So COVID-19, again, there was an adjusted analysis, and then there were many other meta-analysis. So after that, it was recommended that intravenous iron is can be given. It's a class 1 level A evidence to improve the symptoms and quality of life in heart failure patients. So according to recent guidelines, we need to use the quadruple therapy, and finerenone is recommended in patients with type 2 diabetes mellitus and CKD to reduce heart failure hospitalization. Intravenous iron supplementation is recommended to reduce the hospitalization risk. So just to put it in a nutshell, in the ED first contact, we do a hemodynamic profiling. Is the patient wet or dry? Is he warm or is he cold? Then you can initiate if he's hypoxic, you can start with the nasal cannula. If he's still hypoxic, you can put them on an RPM, but best is to go with a 9 IV support and then intubate them if required. Initiate IV diuretics early and address the precipitating factors. So it could be ACS, P, arrhythmias. Please address the precipitating factors to worsen the situation. Otherwise, it could worsen the situation further. You can use the CHAMP mnemonic for the differential. So any cardiac cause, C, cardiac, hypertensive, arrhythmia, mechanical causes, or pulmonary embolism. So this is what we discussed in the causes. This is a mnemonic you could use to differential what could be the possible cause for this particular patient in acute heart failure. So what are the emerging therapies and innovations? You have cardiac contractility modulation, which is being done. So they modulate the contractility, and this enhances the systolic function. This has been FDA approved. It's still not yet available in India. Probably will be available in India shortly. Then there are gene therapies with SERCA2 and MIDCAR. This has been shown to increase the calcium cycling, and this is in phase 2, and it has to be shown very promising. There are some other agents under investigation like istaroxime for dual. So this can be used for dual inotropic and lusotropic effects. So ED, you diagnose, stabilize, initiate oxygen diuretics, begin quadruple therapy as an inpatient. Post stabilization, you can evaluate. Once they're stabilized, evaluate how much their deficiencies, and if they require a CRT or an ICD to be inserted or to be placed. Advanced phase, if they are really not responding to either of these, then you can consider CCM, gene therapy, and other monitoring devices. So take home points: early aggressive stabilization is key in the ED. Quadruple therapy improves outcomes, initiate it early. Integrate any advanced therapies in refractory cases, and standardized protocols and visual aids will enhance the implementation. Thank you.
Thank you very much, ma'am.
Thank
It's
you,
a truly
Madhukiran.
informative and clinical relevant session.
Yeah,
And we'll wait for a couple of minutes, ma'am. If anyone, any questions, we'll ask. We'll wait.
sure. Any questions?
Okay, ma'am. I think no questions from the
All
attendees.
right. All
We'll
right.
wind up the session. And once again, thank you so much, ma'am, for
Thank you,
your
Dr.
updates.
Madhukiran.
And
Thank you.
thank you, Yashoda Hospitals, for conducting academic activities like
Thank
this.
you, Yashoda. Thank you, Dr. Madhukiran. I thank the organizing team. Thank you so much for giving me this opportunity. Thank you.
Thank you.
Thank you.